Season 1 of Medsplaining is brought to you by Estée Lauder. With 40 years of night repair expertise and 30 years of collagen research, Estée Lauder are the experts in nighttime skincare. I'm Dr. Jennifer Zelovitzky, and welcome to Medsplaining. You know, it's a really exciting time of year when we're recording this. It's about to be the Thanksgiving break, and both of my girls will be home from university to visit. I'm really excited to see them and to properly catch up, just to give them a hug. I'm sure there'll be mountains of laundry, which I will reward myself for with lots of pumpkin pie. And then I'm heading off next weekend to the new Pause Symposium in New York City, where I'm really excited. I'm going to be fangirling really hard. This is going to be a symposium featuring so many of the doctors and experts that I admire and follow on social media, like Wendy Suzuki, Mary Claire Haver, Dr. Vonda Wright, Corinne Men, Dr. Avram Blooming, who wrote Estrogen Matters. These are just the rock stars of the new wave of menopause experts. So I will be bringing you lots of exciting reels and takeaways from that symposium. I'm really, really excited. Also, on a personal note, I'll be attending my first live Peloton class. So, I mean, that's just a win for me because I've never been to the studio. I've never ridden live. It will be my 3,000th ride, I think I'll be celebrating. So I'm hoping to get a shout out there. And of course, I'll share that too on my socials because it's kind of fun. I'll take you behind the scenes a little bit there. Anyway, this is a solo episode for me today where I'm going to be tackling one of the number one topics that I get asked about, which is basically menopause hormone therapy myths and misperceptions. And it features a follower question, which I really appreciate. I'm always happy to have you reach out through the comments or DMs if you have any questions or specific things that you've heard or seen in the social media world that you're not sure if they're true. I love debunking myths. I love addressing misconceptions and misperceptions because this is how we learn and grow. And often I have to delve into the research to see if maybe there's something I wasn't aware of. You know, we should never be ashamed to ask the question, right? Like our teachers used to say, there are no stupid questions. I'm always happy to address them. And so reach out anytime. And without further ado, let's delve into some of these misperceptions. And I'll be using HRT, which is hormone replacement therapy, interchangeably with MHT, which is the newer way of describing it, which is menopause hormone therapy. Because we're actually getting away from this idea that we're replacing something that's missing. Although it could be interpreted that way, not every woman needs hormone therapy or would benefit from it. So it's something that can be useful in the event that you have symptoms, but doesn't mean that everybody should be on it for preventive reasons, because I don't think we're quite there yet in terms of the research. So before we delve into the first question, let's take a quick ad break. Estée Lauder's Advanced Night Repair Serum and new Revitalizing Supreme Night Power Bounce Cream work together to give you youthful, radiant skin. The serum minimizes key signs of aging, while the cream boosts collagen and improves the skin's bounce. Experience the power of this dynamic duo for visible results overnight. So question one is, what is hormone replacement therapy? Well, typically, hormone replacement therapy consists of estrogen and a progesterone if you have a uterus. So if we give you estrogen on its own, it eventually would lead to the uterine lining becoming thicker and thicker, which could eventually lead to what we call hyperplasia, abnormal thickening. Or if we let that continue to grow, it could develop a uterine cancer. So when doctors were initially giving women estrogen, they discovered pretty quickly that these women were having a higher incidence of uterine cancer. So they realized you have to balance it out by giving some progesterone or progestogen, which is a name for a synthetic progesterone. Sometimes we add a testosterone because that can be useful if there's persistent low libido or very low energy. It can sometimes help. It can be also helpful to realize that although our estrogen and progesterone do tend to decline pretty quickly at menopause, testosterone doesn't decline as rapidly. And often we don't really notice a decline in those levels until later, around age 70 or 80. So question 2 is, how does menopause hormone therapy work to relieve the symptoms of perimenopause and menopause? And this is a great question. So we have estrogen receptors pretty much everywhere in our body, everywhere from our head to our toes. This includes our brain, where it controls our temperature regulation, our mood, our sleep, and then our skin, and in our bones, in our arteries and cardiovascular vessels. So it's really important to realize that for women, estrogen plays a key role, not just in the classic things like hot flashes that we would think of, but in terms of, how we feel about our skin, whether it's itchy or dry. It can lead to the development of cardiovascular disease as it declines. And so there are certain things that hormone replacement therapy is very, very, very well known for doing, which is relieving hot flashes, helping with mood, and helping with sleep. It can certainly help some patients with respect to their skin symptoms, although I can't say it's always a slam dunk in that area. I do have patients that need to use some combination of hormone therapy and some external creams or medications to help with their skin symptoms. And we know for sure it helps to prevent osteoporosis and fracture. That's because it not only can help preserve bone density, but also bone resilience, meaning a bone that is more flexible and resilient is less likely to break in the event of a fall. So we know that estrogen helps in all of those ways, and progesterone mainly plays a role in stabilizing the lining of the uterus to prevent that hyperplasia and abnormal bleeding and cancer that we discussed in question 1. Now, progesterone also can help with sleep, and so many women take it at bedtime because it does tend to sedate you a little bit, which is the only side effect I get women actually smiling when I tell them about. So hormone therapy is really effective at what it does because it really directly attacks the problem, which is the decline in estrogen and the sort of air hunger that the estrogen receptors develop as estrogen levels decline. About 80% of women experience some symptoms at the menopause transition. And so for them, hormone therapy can be very, very helpful because it directly goes to those estrogen and progesterone receptors and gives them what they're air hungry for. There are other therapies, non-hormonal therapies, such as medications like venlafaxine, which is a serotonin norepinephrine reuptake inhibitor, that are quite effective at managing hot flashes. They can be less effective in terms of things like preserving your bone density. They don't really have any impact on that. They can be helpful with mood, but one thing that I always like to point out is that estrogen is an important modulator of our brain's neurotransmitters, so norepinephrine and serotonin. So it's no accident that women often come to me and say that they were put on an antidepressant for their mood symptoms and their hot flashes, and they feel it's not really as effective as they wish it was. This is because without the estrogen levels being replaced in some way, you don't get the same effect from the antidepressants as you would get in your 20s or 30s. So a question that I got directly from a follower, and I really appreciate this, is what do I do if I was put on HRT and it isn't working for me? So often what I see, at least in reality out there in the community, doctors are very pressed for time. So they will often start you on something and then say follow up in 6 months or a year. The problem is that hormone replacement therapy is not a one-size-fits-all approach. It takes a lot of adjustment and titration to find the right dose and combination for each individual patient. And so often women feel it's not working for them, but really it's not the right dose or the right type of hormone therapy. So we know that we can deliver estrogen as a pill, a patch, or a gel. And sometimes women just take to or absorb one particular formulation better than the other. Some women require a slightly higher dose than others. Others require a lower dose. we don't know what your individual receptors are going to do with it until we start it. So often we will start with a low dose and work our way up every 4 to 6 weeks, depending on the response that you have to your symptoms. But it's a great question because women give up thinking it doesn't work for them. There are very few women that won't derive some benefit from hormone therapy in my experience. The next question is, why is it still considered so taboo to use HRT for menopause symptoms? Okay, so to really get into this, we have to go all the way back to the 90s when they started the Women's Health Initiative trial. This was a massive trial of tens of thousands of women. And this trial was started as a prevention trial. So they didn't really delve into the symptoms women were having for menopause per se. They wanted to see if hormone therapy could prevent breast cancer, cardiovascular disease, osteoporosis and fracture, stroke, diabetes, you name it, all sorts of chronic ailments. And so they had two arms. Women who had a uterus had to have some progesterone. So they were given oral progesterone, progestogen, and estrogen. And the other group who had had hysterectomies and didn't require a progestogen were given just oral estrogen on its own. And this was Premarin at the time. It's important to note. So they followed these women along. And after 5 years, they noted that among some of the women, there was an increased risk of breast cancer, and they stopped the trial. It's really important to understand, though, that nobody seemed to look at the fine print. So in the group that received estrogen alone, there was about a 23% reduced rate of breast cancer diagnosis. And following those women for another 20 years did not reveal any additional increased risk or any increased risk of death from breast cancer. So it seems that the estrogen on its own actually reduced the risk of breast cancer across all ages from 50 to 79. Now the other group, the progestogen, which was medroxyprogesterone acetate, which is still used but is not the first line anymore, plus Premarin. That group of women, there was a very small increase in breast cancer. And when I say small, let's put it this way. The group receiving a placebo had 30 out of 10,000 women diagnosed with breast cancer, and the group receiving HRT had 38 on 10,000. So for 8 out of 10,000 additional women, which was the absolute increased risk, the headlines got out that HRT causes breast cancer, and that arm of the trial was stopped prematurely. This caused the use of HRT to plummet below 5% and remained there for 20 years until finally somebody went back and said, I think we should investigate this data. And the truth came out. I think another big issue here is that breast cancer is classified as estrogen receptor positive or negative, or progesterone receptor positive or negative. And so there's almost this false belief, I would say, that means that tumor is fed by estrogen and progesterone. That's not true. It's more of a descriptor of a protein on the surface of the tumor cell. It doesn't necessarily mean that it is fed by estrogen or progesterone. And in fact, women, when they are young, have far higher levels of estrogen in their body. When they're pregnant, they have much, much higher levels of estrogen. And yet we do not see higher rates of breast cancer in younger women or in pregnant women. In fact, there were several studies done on women who got pregnant after surviving breast cancer, and they also didn't have a higher rate of recurrence. So I'm part of a group of doctors who's very, very eager to debunk these myths. Unfortunately, the guidelines haven't really kept up with the newer science and discoveries. And of course, we need another really big randomized control trial, like a newer version of the Women's Health Initiative, and the funding just isn't there. So it's really still a tricky subject to get beyond those taboos and those misperceptions when it comes to using hormone therapy and this fear of breast cancer. I also want to say, though, actually, on this topic, women are 7 times more likely to die of heart disease than of breast cancer. We live in a time where early detection really has led to immense improvement in survivorship for breast cancer. And that's not to say it's not a scary thing to face. It certainly is. But it's similar to getting in a car versus a plane. You know, we get in a car every single day and we don't even think about it, even though the risk of dying in a car crash is so much higher than dying in a plane crash. And yet so many people are fearful of flying. So it's that same thing. We don't think about the cardiovascular risk, which might be mitigated or prevented by starting hormone therapy early. But we think about the breast cancer risk, which if we get our mammograms, if we stay on top of things, there's a much higher likelihood of cure and surviving your breast cancer. So the final question is, how can women advocate for themselves when they're seeking relief for their menopause and perimenopause symptoms? This is a great question. Unfortunately, I don't have a straightforward answer. The problem is that I feel that the education system and the funding for women's health, particularly beyond the reproductive years, has not kept pace with what the public is demanding. And often my patients come to me having a better understanding of the current thought process behind HRT than their primary care providers. Now, this isn't the provider's fault. We are taught nothing in family medicine residency about this. I wasn't even taught anything in my OBGYN rotations about this. It's just very unfortunate. What I would say is you have to come in with a strategy. I'll never forget a patient who came to me. This is when I was in family practice and I knew nothing. And I thought if I started someone on HRT, I was for sure giving them breast cancer. She came to me and she said, I want to start Duaviv, which is another medication that we use for HRT. She said, I have read about it. I understand there might be some risks, but for me, I'm willing to accept them. And I would like to start it and see how I feel in 3 to 6 months. And I remember reluctantly giving her the prescription. But what it did was it forced me to go and look into Duaviv. And then I followed her along for several years. And I saw that she felt so much better, that she had a better quality of life. And none of the things I was fearful of actually happened to her. And so it was much later that I became a certified menopause provider, but I will never forget her. And I think that patients do have a role to play in going to their doctor and saying, I have looked at the evidence. I understand there might be some risks, but I am willing to accept them. And I would like to try XYZ. And I think that's very reasonable. And I think it's also important to really impress upon your doctor the quality of life issues that you're having from your menopause symptoms. I think that doctors don't really have a deep enough understanding of the myriad ways that perimenopause can throw us for a loop, from chronic sleep deprivation, irritability, brain fog, inability to function at work. 1 in 10 women is leaving the workforce because of untreated menopause symptoms. That is unacceptable when we have a therapy that is safe, effective, widely available, and should be on the top of mind for every family doctor when they see women above the age of 40. Another thing I want to kind of insert here, because it's another way that women have to advocate for themselves, is if you're in perimenopause and you have symptoms that are beyond just irregular or heavy menstrual cycles, advocate for yourself to try something other than an oral contraceptive pill. It's not to say that these can't be very helpful. If you have heavy bleeding or very irregular cycles, and that is your predominant symptom, and you are low risk and you are perimenopausal, it's absolutely a reasonable option. But I see too many women come to me with pervasive sleep and mood symptoms, and they would gladly trade some irregular bleeding or heavier bleeding to get rid of those symptoms. And we know from the research that oral contraceptive pills are not very effective in managing mood or sleep. So although they can be helpful, I find with mild hot flashes, they don't often show the same efficacy for severe hot flashes. And so I think it's reasonable to say to your doctor, I understand that I'm perimenopausal, that I still need contraception of some form until I've gone a full year without a period, but I can I can find other ways to manage that, I would really like to try HRT. And this can be done cyclically for women who are perimenopausal, meaning you take the estrogen continuously, but you take the progesterone or the progestogen 12 to 14 days of the month. That's a pro tip that I'm giving you because I just see it too often in the women that are coming to me. I've really enjoyed answering your questions, and I would love to gather up more questions for a future episode. So if you have a topic or a question that you'd like me to address in a future episode, reach out, DM us, go to one of our socials. They're all listed in the show notes, and reach out because we do see your questions, we see your comments, and we love them. And it's the best way to address these things is just to tackle them head on. Have a great day, and thanks for listening. Don't forget to follow us on Instagram, Facebook, LinkedIn, and TikTok at Medsplaining. If you have any questions, shoot me a DM. And if you like this episode, the best thing you can do is tell a friend or rate and review it wherever you listen to your podcast so other women can discover it. And don't forget, if you're listening to this, you may be happy to know that we video every single episode, so you can watch it if you prefer on YouTube. See you next week. Medsplaining is produced by Ghost Bureau. Thank you for tuning in to Medsplaining. While we strive to provide accurate and insightful information, this podcast is not a substitute for professional medical advice, diagnosis, or treatment. The opinions expressed by our host and guests are their own and should not be interpreted as medical advice. Every individual's health situation is unique, and it is crucial to consult with a qualified healthcare provider regarding your specific concerns and conditions. Additionally, any links, resources, or references mentioned in our episodes are provided for informational purposes only and are not sponsored by Medsplaining. The producers and hosts of Medsplaining assume no responsibility or liability for any actions taken as a result of listening to our podcast. We encourage you to use the information presented here as a starting point for discussions with your healthcare provider. Information and references are subject to change based on scientific evidence as it evolves over time. The hosts and producers of Medsplaining are not responsible for future changes to the information and references and assume no obligation to update based on future developments. Remember, your health and well-being are paramount. Thank you for listening, and we look forward to exploring more topics in women's health with you in future episodes.